Thanks for having me on tonight. I've done this twice in the last couple of months, I guess, before the new year. Back in 2020, I did two. I did one on the art of auscultation, and we talked about vital signs. And then I did another that was abdominal trauma, I believe. And tonight, I want to talk about differentiating causes of chest pain. So my name's Ginger Locke, and I teach paramedics in Austin, Texas at the community college here. That's my main gig. And then in the last 4 or 5 years, I also started a podcast that was for the paramedic students. And it's called Medic Mindset. And in fact, this title of the lecture tonight is a title of one of the episodes. So I don't remember how long ago, but I started this series within Medic Mindset called the Thinking Series. And what I would do was talk to very often a EMS medical director, but sometimes paramedics, about how they approach patient types, right? So the shortness of breath patient, or chest pain, or syncope. And we would spend about 45 minutes to an hour really trying to hear from them. Hey, when you hear this, like when the dispatch info is chest pain, what are your kind of first thoughts? How do you order your thinking? How does new data change your differential diagnosis and what you think might be going on? How does hearing that it's a 30-year-old chest pain, how does that differ from hearing maybe it's a 70-year-old with chest pain? And I just kind of give them these types of scenarios just to try to pull out how they think through all of this, because it's such a challenge to have to, in emergency medicine, be treating while collecting data, right? We're very often like starting treatments with very incomplete kind of pictures. And so it's kind of a cognitive nightmare to have to be doing while thinking, right? Usually what we would prefer to do is have all the data, think about it, analyze it in great detail, and then formulate a plan. But in emergency medicine, it's a time sensitive sport. And so what we do is we kind of start at the beginning. We start very often just treating symptoms. We just see, cyanosis, and we start oxygen without really knowing the root cause. And then as the kind of call progresses, then we move away from just treating symptoms to thinking, what disease is at the root of all of this? And is there something I can do further to mitigate that disease process? Or if I'm more aware of it, I might take them to a certain hospital versus another, like the STEMI cath lab being the classic example. And I think chest pain is really our bread and butter, because it is what the public we've told them to call us when they're having chest pain, and that we're going to show up and help them decide, is this the big one or not, right? That's very often what they're trying to decide is, am I having a heart attack? And so what I've noticed in emergency medicine, EMTs, paramedics, but also emergency medicine physicians, is that very often our job is to tell people what they are not having, right? So I may not know exactly what disease process is going on, but I can say with pretty strong confidence, I don't think this is your heart. And that's a lot of what people want to hear. So I'm going to talk through what I've learned from having those conversations with these really expert clinicians about how they think through a chief complaint. Usually for us, it's that dispatch info, right? Our thought process starts pretty early as we're going there. And as we collect more data, we start kind of going down different body systems usually. So with chest pain, what I'd like for you to do is in the chat, just write out maybe 4 or 5 diseases that just come to mind when you hear chest pain. And as you guys are typing that in there, thanks. They're starting to roll in. Thank you. I've got my Twitter handle on the screen in case you guys are on Twitter. I'd love to connect with you there. And this is a picture of the website, medicmindset.com. And there's a whole page. So I create a blog post for every single episode. And so there's a blog post that goes with the Thinking Chest Pain episode. And here's a picture of a chest, right? And these are the kind of usual suspects. We got the heart and the lungs. All right, let's see what you guys put in here. Danny, thanks for linking to the podcast. Appreciate that. So we've got CHF, we've got, yes, GERD, gastroesophageal reflux. I love it that you remembered. We've got whole GI structures, right? The esophagus courses through the chest, right? So we forget sometimes that there are GI structures in the chest. But it's important to remember it because GERD is so common. Atherosclerosis, ACS, angina, GERD, angina, pulmonary embolus, pneumothorax, pericarditis, very good, traumatic injuries, indigestion, which is another word for GERD, angina, acute MI, costochondritis, another common one that's not so scary, but very, very common. A lot of people get sent home from the ER with a diagnosis of costochondritis, and I will talk about that in this lecture. Broken ribs, COPD, pleurisy. Yeah, you hear a lot about pleurisy. I'll talk about what that is. Pneumonia. Yeah, pneumonia can hurt, can cause chest pain. Muscle strain. Yeah, musculoskeletal. So when we think of chest pain, sometimes it's almost becomes synonymous with acute coronary syndrome. And we call them chest pain patients, right? Anxiety is on the list. An aortic aneurysm. Cholecystitis, the gallbladder, can radiate into the chest. Excellent. So when we think of the chest, we've kind of been shown this picture, right? And we think major structures, big vital organs, the heart, the lungs, the aorta. And what I want to do in this lecture is really help you build what's called a mental model, right? A mental model is basically your ability to have a framework for how to guide your thinking. So if I were to say to you, how does a bicycle work? You might have a frame for that. There's gears and there's pedals and all the parts and pieces. And if somebody were to just throw it all out in the driveway, you could kind of put it all back together like a puzzle. And that's what I want to do for chest pain is create this model. So when you go into these calls and you've got to think through what could be causing this, where to start, right? You don't just start where the patient takes you. You kind of have a plan, an approach. So in emergency medicine, we usually think worst first. That's our job. That's what the public is kind of counting on. They call us for us to either reassure them that the worst isn't happening or to discover the worst thing, right? And it's our job. It's very often our job to tell people what isn't happening, right? It's our job to say, I don't think it's this. I don't think it's a heart attack. I don't think it's your heart. I don't think this is your lungs. I don't think this is a PE. these really terrible, scary things. We may not know for sure what's going on, but we screen really, really heavy for these worst conditions. And I'm going to outline what those are for chest pain. And then it's really important to talk about the common conditions that cause chest pain because they are common. And we need to recognize those as well. And you guys brought up things like GERD. I mean, gastroesophageal reflux is almost synonymous with being American, right? It follows that whole kind of trifecta.
This is that Nite. I love her.
It's like following that same, we eat unhealthy foods and then we're overweight and we're sedentary and all these things, right, that lead to GERD. So it's so pervasive in the US. You really need to know what it looks like because it's common. So we'll talk about those common things too. You've heard in medicine you may have heard if you hear horse beat, right, the hooves beating, right, and they're behind you, you shouldn't imagine that a bunch of zebras are running up behind you. You should think horses first if you hear hoof beats. And that's kind of true. We should think of the common things, the most likely thing that's going on. But we also need to think what's the worst thing. So we do both. We think what's the worst possible scenario or scenarios, right? What are the scariest things that could be going on? We screen for those first. As it starts to not look like those, we start thinking, okay, well, let's think of the common things that this might be. So the worst stuff, many of the things that you guys listed, acute coronary syndromes and MIs. So things like the angina that y'all listed and MIs, aortic dissections, right? So a tear in the aorta, a pulmonary embolism. And I'm going to talk about every single one of these before we leave tonight and give you what's called an illness script, right? So there's kind of these textbook presentations of a pulmonary embolus. The textbook is just that. It's kind of the textbook illness script, and not all patients match that perfectly, but we can at least start with kind of what's the standard kind of bread and butter presentation of the disease. A pneumothorax, pericarditis, esophageal rupture, pancreatitis, which isn't in the chest at all, it's in the abdomen, and pneumonia. All of these things, incredibly time sensitive, incredibly life-threatening, and all cause chest pain. And it's really our job to kind of screen every patient to make sure it is not that. Right, so before you decide, I think this is looking like GERD or the anxiety or costochondritis, we have to be really, really diligent in making sure it's not these things. So we'll talk about those. The common conditions, the ones that aren't super scary, GERD and a hiatal hernia. So a hiatal hernia is where a little bit of the stomach herniates up into the chest, tiny little bit. And it makes that sphincter between the esophagus and the stomach, it makes it weak. And so it leads to GERD. So hiatal hernias and GERD are almost one and the same. It's rare that it would be rare to not have GERD if you have a hiatal hernia. Costochondritis, I'll talk more about that, but that's chest wall inflammation. Esophageal spasms, incredibly not scary, but very, very painful and strongly mimic MIs. And then this pleurisy thing that we hear about all the time. So the way to approach chest pain, you kind of have one of two ways of thinking about it. And you may use both and kind of overlap them, but in general, people will think about diseases, chest pain, for example. We think, okay, it's chest pain. So there's pain in the chest. What's in there, right? You just think about what's in there. I've got skin, I've got sternum, I've got chest wall, I've got pleural lining, and you just go superficial to deep or deep to superficial, and just think through the organs that are present there where they're having pain. That captures a lot of it. Another approach is to think about it in terms of body systems, right? Does this look cardiac? Does this look gastrointestinal? Does this look musculoskeletal? So if you do the body region approach, you can kind of use a visual. You kind of take yourself on a visual journey. All right, and this is a CT of a chest. I know it looks like abdomen, but there's a lot of chest stuff in here too. So the way the diaphragm is shaped, the way it's kind of concave, it's possible. So the way CTs work is they look from the feet up. You've got the spine at the bottom of the screen. You've got the sternum I think that's the sternum at the top of the screen. You've got little ribs around. Outside of the ribs, you see soft tissue and adipose tissue. And then you've got labeled structures. The aorta is this perfect circle. You've got a collapsed or, not perfectly round esophagus. It's more just kind of a muscular looking bit. You can think, okay, I'm going to think about, first of all, is their pain, deep? Are they complaining like this dull, deep pain deep down inside, right? The aorta, the heart, the big stuff in the middle. The big stuff in the middle are the scarier things, right? It's almost like as you move from deep to superficial, it gets increasingly less concerning, right? So deep structures like the great vessels, the heart, the lungs, and you can just visually walk yourself out from there. Here's a better picture. It's not a CT, it's a cross-sectional kind of drawing. So again, you've got aorta, great vessels, the heart itself, ribs. You've got the muscles of the chest, the pecs. You guys were referencing trauma, right? There's always the possibility of trauma, broken ribs. So if you're working in to out, we think about heart, the pericardial lining, the aorta, the esophagus, the lungs, the pleural lining, the sternum, the ribs, and the skin. The abdomen and the chest are neighbors. So anytime somebody has abdominal pain, we've got to think about the chest. And anytime somebody has chest pain, we've got to think about the belly, right? They're only separated by one, muscular diaphragm. That's it. And depending on where people are kind of in their breathing cycle, particularly with trauma or penetrating trauma, you really should think of both. Remembering that many abdominal structures, the abdomen is not very well innervated in terms of pain. So it's not really smart at knowing exactly what is hurting. So that's why you see referred pain. For example, from the spleen, it'll refer to the shoulder. Same for the gallbladder, to the right shoulder. So knowing that abdominal pain is sometimes confused by the spine and the brain as chest pain, we've got to always remember to think about abdominal stuff as well. The body systems approach, this is an infographic that a really, really cool guy made. And you can see basically how they listed it was by body system, right? You've got cardiovascular, pulmonary, GI, musculoskeletal. And then the color coding that you see, he indicated that basically this is kind of a list of worst to least scary, right? To me, everything cardiovascular is pretty darn scary. But look at GI, right? We've got things like esophageal rupture, which is terribly concerning, terribly rare as well, but terribly concerning, all the way down to like a peptic ulcer. And you've got your GERD, your esophageal reflux in there, right? So the blue stuff, the blue conditions are not as concerning. And you kind of put this middle ground. And then the red ground is like danger. And he breaks it out into body systems. So the worst stuff, acute coronary syndrome and MI, right? So what I'd like for you guys to do now is put in the chat, when I say MI, when I say heart attack, what signs and symptoms besides chest pain, because all of these have that in common, what signs and symptoms do you think about? We're building an illness script. Excellent. I see lots of good stuff rolling in here. Shortness of breath. A lot of you guys kind of honed in on the skin signs, pale, cool, sweaty. Sense of impending doom, Frank says. Radiating pain, the jaw, the left arm, the armpit. Yeah, and the quality of the pain in the chest, right? So usually they wouldn't report it as a sharp pain. Instead, it's Michelle says it's heavy, right? It's that pressure. It's a heavy dullness. That's one of the ways, right? The quality of the pain is how you can begin to differentiate it from other conditions. So, for example, esophageal reflux or GERD is more of a burning pain, or a pulmonary embolus is more of a sharp pain. Aortic dissection, more of a tearing pain, right? And so that's why we assess for the quality of the pain. What does the pain feel like? And that's just one data point. That's just one, we do one test, right? And asking a question of a patient is a test. We say, can you describe the pain in your own words? And they say, I don't know. It just hurts. And you're like, okay, maybe you give them choices. Does it feel sharp, like I'm stabbing you with the pointy finger? Or does it feel more dull, like I'm pushing on you with a whole hand, or a heaviness? Right? You can give them some choices. Generally, we, again, textbook wise, illness script wise, we think of this heavy pressure as going with ACS and MI. And the associated signs and symptoms are many of the ones you guys have listed: the radiating pain, the shortness of breath, the skin changes. What we can also add in are risk factors, right? So there's something called pre-test probability. And that basically just means before I do any tests on them, before I even ask them any questions, the likelihood of the 55-year-old's chest pain being an acute coronary syndrome is higher than the 6-year-old chest pain, right? That's called pre-test probability, and really just talking about risk factors. So now put in the chat what you remember about risk factors for acute coronary syndromes or MIs. Because if you know the risk factors, you can ask them specifically about that. And we start there. Remember, it's our job to tell them it is your heart or it's not your heart. Right? So we just collect all this data. Right. So you go hunting for it. They may never offer up that they're currently 55 and their parent also died from sudden cardiac arrest at 55, right? They may not put that together to tell you that. But as many of you guys said, that is it hereditary? Is there a history of this in your family? Is something we should explicitly ask. Smoking, obesity, high blood pressure, diabetes, high cholesterol. Right, that puts them at an increased risk for acute coronary syndrome. So we're screening for risk factors. We've asked about the quality of the pain, maybe does it radiate, right? Working through OPQRST. And now think about, and you guys talked about skin signs, right? If somebody's having an MI, right? An MI means there's a clot in a coronary artery, usually a clot, something obstructing blood flow in a coronary artery, often a clot. And that lack of blood flow to the part of the heart, part of the left ventricle, means that the heart's not pumping strongly. And so blood can back up into the lungs, right? So you can see signs of heart failure, right? Things like pulmonary edema. So they get some shortness of breath. And then we've got all the EKG business that ALS providers can do to help screen for MIs. Because really what we're trying to decide is, do I start treating this as an MI, right? And the treatment, many of you guys are charged with that decision. I mean, you're making a diagnosis. You're deciding, do I give them the treatment for acute coronary syndromes? Things like aspirin, things like nitro, which are not benign medications at all. In fact, they're quite strong. Those are pretty strong medications. We give them because they can confer tremendous benefit, but there's actually tremendous risks associated with those medications. So we want to be confident that it is worth the risk of giving them the medication in order to benefit them if we really strongly believe that they're having an acute coronary syndrome. So risks of aspirin, right? If they have a GI ulcer or peptic ulcer, right? A bleeding gastric ulcer, which, by the way, can cause chest pain. We don't want to give them aspirin. So at the BLS level, we have to be good at differentially diagnosing. You've got to decide not all chest pain gets aspirin. Not every single chest pain patient gets aspirin, right? The ones that you think are having an acute coronary syndrome get aspirin. Not every chest pain patient gets nitro. We save those two medications for when we believe it's an acute coronary syndrome and we believe it's not other stuff. All right, the next thing on our list is aortic dissection. Again, something that causes chest pain, but something that you wouldn't want to give aspirin to. So aortic dissection, I wanted to use the whiteboard for it. That's why we were trying earlier to make it not glary. So we'll see what happens. What do you think, Danny? Do you like it? Okay. We'll see how it goes. So this is the heart, okay? Let's see. This is the left ventricle. And the left ventricle, with quite a bit of pressure, pumps blood to the aorta. The aorta branches into the right arm and the left arm. This one also goes to the head, okay? There's a valve here, the aortic valve. And probably the place that has the most pressure in your body in terms of the vascular structures is right here in this arch. And what can happen over time medically is that you can, because of hypertension, you can begin to get little small tears in the middle lining, or sorry, the tunica intima, the smooth lining of the aorta. And what happens is it's a little tiny tear, and that little tiny tear will allow for blood to go into a false lumen, a false hole. It doesn't rupture the aorta, it dissects the layers of the vessel. Okay. And that's why we call it a dissection. Sometimes people think dissection means to cut open, and because we dissect, in cadavers and things like that. This means dissecting the layers. So there's 3 layers. The walls of the aorta are really muscular, right? So you've got the smooth lining, you've got a muscular layer, and then this tunica externa that holds it all real firmly. When this tears, it causes a lot of pain. And the aorta is very deep inside the body. It's very central, right? And so because it's so deep, sometimes that pain radiates to the back. And that is part of the illness script of aortic dissection, is a tearing pain that radiates kind of between the shoulder blades. And the reason it's between the shoulder blades is because often these thoracic aortic dissections are happening kind of around the arch. They can sometimes even happen right here at the outlet, right when it comes out, pressure right there. If they are in aneurysm, and I call it an aneurysm because an aneurysm just means a bulging out, right? So that's what happens. It dissects the layers and it causes it to bulge out in an aneurysm. If that happens around the outlets for the left or right arm, then you can get unequal pulses, unequal strength of pulses in the right versus the left arm. So you may have been taught somewhere along the way to check both pulses at the same time, right? To rate the radial pulses at the same time, right? You come up and you feel for their pulses. If they feel unequal, right? Or if you take a blood pressure on one side and it is different than the other side, that can be a finding associated with thoracic aortic aneurysm. That finding alone wouldn't send you down the road of screaming, this is a thoracic aortic aneurysm. But as you start to get enough of a collection of signs and symptoms, you get a full clinical picture. Like, I wonder if this is what's going on here. They've got risk factors. So the risk factors for aortic aneurysm, hypertension is a big one. Age is a big one, right? There's got to be time and wear and tear on the vessel, basically, over time. And the wear and tear comes from uncontrolled hypertension, largely. It can be trauma-induced. All of this could tear right from trauma. But when it happens suddenly in the medical kind of patient, it's often because of hypertension, and the risk factor is age, many years of uncontrolled hypertension. They get unequal radial pulses. The tearing, chest pain radiates to the back. You've heard of an abdominal aortic aneurysm, same process, but in the abdomen, right? It doesn't cause chest pain, it causes abdominal pain. But because it's so distal to the arch, they don't get these unequal pulses in their arms or anything like that. They get really heavy legs that aren't they aren't getting much blood flow, and pedal pulses that are hard to find. That's abdominal aortic aneurysm. If the dissection happens close to the aortic valve, you can get murmurs, right? Systolic murmurs. But the classic findings is that it's tearing in nature and radiating to the back. Real concerning. These can sit here stable, right, and not rupture, but they're kind of handled as if they might rupture at any time. So these patients are handled carefully. We're not giving big fluid boluses or anything like that, trying to increase their blood pressure or anything like that. Kind of worried it might rupture at any time is the approach. All right, we've got pulmonary embolism on our list. Pulmonary embolus is one of the leading causes of sudden cardiac arrest. I think acute coronary syndromes gets a lot of press, but PEs, pulmonary embolus, is a very common condition that's very, very life-threatening. And the way first I should say what a pulmonary embolism is. An embolus means that something's in the blood traveling around that shouldn't be in there. So an embolus it can have an air embolism, you could have a bacteria embolism, you can have cancer embolism. The most common type of embolus is a clot, though. Right? And the very standard way that a pulmonary embolus comes from, right, where this clot comes from, is from a deep vein thrombosis. That means a clot in the legs. And you may have heard that a risk factor for PE is this prolonged travel or prolonged sitting. You hear about this if you've gone on long flights, they tell you, to get up and move around or move your legs and all of that. It's so you don't get a deep vein thrombosis, a clot in your legs, that once you stand up, it starts traveling around. It comes back to the heart and then gets pushed to the lungs. When the clot lands in the lungs, what happens is it blocks blood flow to the lungs. And we know we need that blood to go to the lungs to release CO2 and pick up oxygen, but it can't do that because it's blocked. And so you get what's called a ventilation perfusion mismatch. They're ventilating just fine. Air's going in and out of the lungs just fine, but there's no perfusion, there's no blood getting there for gas exchange. And so one of the hallmark features of a pulmonary embolism is low O2 sats. Right? Low O2 sats that you give them oxygen, you just can't seem to get them to pop up. Another one is tachycardia, is fast heart rates. A lot of people will be screened in the ER for pulmonary embolus just because they have sustained tachycardia, just because they can't figure out why else this person is just sitting there tachycardic. So if you're building an illness script for PE, you kind of want a story of how it could have happened, right? This deep vein thrombosis story is a common one. Some people just have clotting diseases where they're just hyperclotty. We know that COVID is causing people to have some clotting disorders. PEs are coming up a lot with that. So PEs are something that really need to be on your radar. So the illness script is tachycardia, low O2 sats, some type of story that goes with it, chest pain, it hurts. And the pain that they feel is sharp and localized to one area. It's not like this pressure across the whole chest. Usually they can kind of point to the spot that hurts. So it's sharp chest pain. And if the PE is big enough, and they can get really, really big, right? It can be a clot that's forming and can get really, really large, and it blocks a lot of blood flow, you can get where the heart backs up and you start to see jugular venous distension, right? Because the right side of the heart is not doing its normal pump to the lungs, it's stuck. So everything that drains to the right side of the heart, specifically the jugular veins, it backs up and you see jugular venous distension. The next one on our list is pneumothorax. And that's a pretty rare one medically speaking. It actually happens pretty commonly from trauma, from chest trauma. You can get small pneumothoraces, but a medical pneumothorax, not that common. But this is when you get air in the pleural space. The lung pops, basically. There's a defect or a hole in the lung, and air starts to escape in the pleural space, between the lung and the chest wall. You start getting air in there. You've heard of maybe a spontaneous pneumothorax, right? Where it just happens because of COPD is a common cause, right? They just have structural problems with the lungs. The pain with this is also sharp. It's sudden. And they've got this respiratory distress to go along with it. Often this is something that gets discovered on X-ray. Another one on our list is called pericarditis. Okay, I'm going to put it in the chat. Peri. Oh. Let's see here. Everyone. So if you break that word down, it's kind of got three parts. Peri means around. Card means the heart. And itis means inflammation. Sometimes we think itis means infection, but it actually means inflammation. And infection often causes inflammation. So that's, I think, where the cross in our brain happens. But pericarditis is inflammation of the pericardial sac, right? Or the lining around the heart. The inflammation is not in the heart itself. It's just the surrounding structures. Sometimes from infection, things like you can get a really common story or illness script for pericarditis is the patient gets dental work and there's so much bacteria in the mouth, right? And some of that bacteria gets in the bloodstream during dental procedures, pulling teeth, root canals, all of this. Some of that kind of the flora in the mouth, germs that do just fine in the mouth, unfortunately get in the blood and travel to the heart, and you get an infection of the pericardial sac. And that causes inflammation. And normally the pericardial sac, it has a little bit of, fluid in there that keeps the friction out because the heart's always moving. If you've ever seen a picture of like open heart surgery, that thing is busy in there. And it keeps it lubricated around it. But if the pericardial sac gets a little inflamed, you get some rubbing, right? The two linings begin rubbing on each other. And it causes positional pain. And what I mean by that is that the patient will say that they feel better if they lean forward a little bit, and it's made worse by when they lay down. All right, so one of the things in OPQRST that we ask is, does anything make it better or anything make it worse? This is when we care about their answer, right? And we may, if we're thinking pericarditis, maybe they have a low grade temperature, a little fever. Maybe they just had dental work. Maybe we listen to the heart tones and we hear a little, what is that rubbing sound? Pericardial friction rub. It's appropriate to ask them specifically, you're laying down right now and it hurts. Sit up with me. When you sit up and lean forward, does that make it any better? Right? So knowing these illness scripts means you can go hunting for the info and you care about the response. You're not just asking, does anything make it better or worse, right? We're not just asking because it's part of OPQRST. We're asking because we know we've studied pericarditis and we know, oh, this goes with that. I want to screen them for that and check that data point. Pericarditis is on the list of scary things because that inflammation can get so bad that it can restrict or constrict the heart and its ability to pump. You can get pericarditis can start to kind of turn into pericardial tamponade, which you may have heard of, where all that fluid starts to squeeze the heart closed. And it hurts a lot. And they're counting on us to differentiate it from acute coronary syndromes. What I haven't mentioned in this lecture, and I should now, because it applies to pericarditis, it applies for thoracic aortic aneurysm, is that you can have more than one disease at once. In fact, I think it's something like 10% of all thoracic aortic aneurysms or dissections also dissect into the coronary arteries. So it's a total pain in the ass because they're having a STEMI and a thoracic aortic aneurysm, right? And in medicine, we call it the sequelae, or the thing that follows MIs. The sequel to an MI is sometimes pericarditis. So it can be a total kind of nightmare when people are doing two things at once, or somebody listed CHF earlier, right? Not only are they having an MI, they're showing signs of congestive heart failure, right? So when that starts happening, then it gets really tough to start differentiating things. And that is the art of medicine when you start having to do that and remember that. It's so easy. We get the disease and we're like, okay, I know what this one is, right? I think I know what's going on here. And we forget, oh, right, two things can be happening. All right. On our list is also of worst things is esophageal rupture. I'm going to throw the list up there again because it's been a while since we've looked at it. All right, so esophageal rupture is what it sounds like. It's when the esophagus ruptures. What causes that? Sometimes it's, caused by us, right? In surgery and things like that. But when it happens at a hospital, it's often from just forceful, violent vomiting, right? So people that have food poisoning or something where they are vomiting like a lot and really, really forcefully. The changes in pressure in the abdomen and the chest and the esophagus, and the amount of pressure that can get generated in there actually is quite profound, and you get tears of the esophagus. So the esophagus can tear and bleed, or all the way up to rupture. The tearing and bleedings, surprisingly, they don't bleed that much. This is different than esophageal varices, which are painless. In this case, esophageal ruptures when the muscle, right, has torn. And the problem here is not really bleeding. The problem here is that we are spilling GI contents into the chest. And that's really, really bad. So all that hydrochloric acid from the stomach now all spilling into the chest or the abdomen, both. And you see, just the chemical damage from all of that being in the chest, and tremendous amount of pain. Again, this one's really, really rare. I mean, I don't know really that many people or many patients that have had an esophageal rupture, but it's still our job to screen for it and make sure it's not that. Right. So if they start telling you, yeah, I was vomiting, I've never had pain like this in my chest before, right? You start thinking, I wonder if that's what's going on here. Pancreatitis was added to the list after that episode that I did with Brandon Blease, the thinking chest pain episode. I had not thought about pancreatitis as being as scary as he reminded me that it is, or he taught me that it is. Pancreatitis is inflammation of the pancreas. And there are two main ways that you can get pancreatitis. One is from acute or chronic alcohol ingestion, right? So just heavy alcohol use. And the alcohol is directly damaging to the pancreas. Or the second common way is when gallstones block the common bile duct and they start backing up the pancreas. So the gallbladder has a duct that squirts bile into the duodenum. Okay, so you've got your stomach, which goes into the duodenum, and then it kind of begins the small intestines. Okay, so this is the duodenum or duodenum, depending on how you pronounce it. This is the gallbladder, right? And it squirts bile in there. The bile is made by the liver. And the purpose of the bile is to help break down fat. There is another structure, the pancreas, that also needs to squirt stuff into the duodenum. And instead of having its own tube, it tacks onto this tube from the gallbladder. This is called the common bile duct. It's common to both the gallbladder and the pancreas. And gallstones, if left untreated, and many people do leave them untreated because of, money or scheduling, and they just don't want to have surgery, right? They'll have a gallstone sitting here. Gallstones can get kind of big. Unlike kidney stones, they're kind of big. And it can block the pancreas from secreting things into the duodenum. And I haven't said yet, what does the pancreas secrete into the duodenum? We know the pancreas is what makes insulin and some important stuff like that. It does all of that kind of blood glucose regulation, but you can kind of think of that as happening over here on the other side. What's going on here is a GI function, and these are digestive enzymes that the pancreas makes. It's what's going to break down proteins and carbs, right? And it secretes it into the duodenum. Usually, if it's backed up, all those digestive enzymes back up into the pancreas, and the pancreas begins to auto-digest itself. And that is very, very, very painful, right? So digestive enzymes are really strong enzymes that break down protein, right? So it starts breaking down itself. Very painful. If you guys have had pancreatitis patients, you know what I'm talking about, or family members that have had pancreatitis. There's just that, and kidney stones are probably two of the people I've seen the most pain outside of trauma. So when would we start thinking, oh, maybe this is pancreatitis? Well, Two are those risk factors, right? We screen. Do you drink alcohol? How much? And then the other is history of gallstones, right? The pain of pancreatitis is sharp, and the location is where the pancreas is. So where the pancreas sits is upper quadrants, and it's pretty deep structure. Kind of sits behind the duodenum. So it's not very anterior, it's pretty deep. All right, pneumonia gets added to the list because it can be so terrible. It can be so dangerous. People certainly die from pneumonia. And pneumonia is infection or inflammation of the alveoli, usually viral, bacterial, sometimes fungal pneumonia. And the pain that's associated with this, I had a little trouble figuring out why pneumonia hurts. I had trouble knowing, is it the lung itself that's hurting? Was the question I was asking myself. And I couldn't seem to find that. Well, everywhere I read, it associated the pain with all the coughing and the respiratory distress that goes with it. So I think I think they start having pain because of all the respiratory effort and coughing. I don't know that the lungs themselves hurt. Obviously, a fever goes with pneumonia, although not all pneumonia has this, perfect fever. Sometimes people are afebrile with pneumonia. You can get what's called aspiration pneumonia, where, bedbound patients or people that have trouble swallowing will aspirate, and then they get pneumonia from that. But because it's inflammation of the alveoli, they have trouble exchanging gas, right? So they can't oxygenate very well. So low O2 sats goes with pneumonia. And a history of something. So usually like a upper respiratory infection or some event that preceded the pneumonia. The lung sounds will be unique in pneumonia, right? They'll have what sound like exudate in there, wet lung sounds, a cough, productive cough, green, yellow, foul smelling sputum. All right, the common conditions, things that once we've decided, it's not looking like any of these worse things, not looking like any of these terrible things. Maybe it's something benign but common, like GERD, right? Reflux, like costochondritis, esophageal spasms, or pleurisy. So we discussed hiatal hernia a little bit already. That's when a little bit of the stomach herniates. It's called a hiatal hernia because the hiatus is the spot in the diaphragm where the aorta, the vena cava, the esophagus, where they go through the diaphragm. It's a hole, a break. Hiatus means break. So a hiatal hernia, unlike some hernias that are visible, you can see them on the abdomen or whatever. A hernia means part of the abdominal contents is not inside the abdomen. It's herniated. It's pushed out into somewhere else. And in this case, it's pushed into the chest. And so there's nothing visible for us to see. We can't palpate this one, but it's in there, right? It's herniated through the hiatus. And that little bit of herniation makes that gastric sphincter not work very well, or actually cardiac sphincter is what it's named. And that's kind of interesting because the cardiac sphincter is so close to the heart, it mimics, right, cardiac chest pain. So many people end up getting a diagnosis of GERD, hiatal hernia, when they thought it was an acute coronary syndrome. but that's only after extensive screening, right? So we do all of our due diligence with EKGs and all that. They go to the hospital, they get further cardiac enzymes, chest x-rays, CTs, right? And they screen for all these really, really scary things. And then they're like, maybe you should go talk to a gastroenterologist because it's not your heart. We don't think it's your heart. Perhaps it's a GI problem like GERD. They may get scheduled still for something like a stress test, right? We don't think it's your heart. Let's do some continued testing. All right, let's move on to costochondritis. Costochondritis is inflammation of where the ribs connect to the sternum. And you can get this from, weight training, physical activity, new physical activity, from coughing. And so costochondritis is often the diagnosis that comes with somebody that's had a long cough that they can't get rid of. And finally, they start getting this chest pain to go with it, right? They've had bronchitis, and they didn't have any chest pain. And then suddenly 3 or 4 days into it, they start having chest pain. It's very often little tears in that cartilage where the ribs connect to the chest, to the sternum. Really benign, right? This is musculoskeletal, right? It's incredibly not scary. And it's one of our last differentials. It's kind of one of the last things we consider because we need to consider all the scary stuff first, right? So you wouldn't want to start here and say, I think it's this, and just spend your whole call confirming that it's that. You need to disconfirm all the other scary suspicions. And then you can start thinking maybe costochondritis. So costochondritis is differentiated from cardiac chest pain in that when you push on it, that can make it worse. When they do range of motion of their shoulders or move around or take a deep breath, that can make it worse. It's truly musculoskeletal, right? Exacerbated by pushing on the musculoskeleton. It's usually sharper in nature. And there's some story, again, that goes with it. Cough, new exercise that they've never done before. Esophageal spasm is another really, really common one. If somebody eats a really large bolus of food, dry food especially, or a big chunk of meat, and they swallow without enough water, without chewing well, that big bolus of food going down the esophagus can cause involuntary spasms, right, in the esophagus. And they're really forceful and strong, and they can hurt a lot. And because the esophagus is smooth muscle, right, it feels a lot like acute coronary syndromes. And nitroglycerin can even relieve these, so it can get pretty confusing about what's going on. Again, this is something it's called a diagnosis of exclusion. That means we've excluded all these other terrible things that we think it was, and now we're left with the benign, not scary thing. We're like, okay, it's not acute coronary syndrome, aortic dissection, pulmonary embolus, right? It's not our list over here. Maybe it was an esophageal spasm. You said it happened right after you put all those, swallowed all those vitamins, but didn't drink enough water with them. Pleurisy you hear about a lot. People talk about pleuritic chest pain. That means sharp chest pain. The word pleuritic, usually they're saying it's sharp in nature. And pleura are the linings around the lungs and the inside of the chest wall. And they can become inflamed. You can get, you can have viral pleurisy. A virus can do it. It can be from smoking. It could be from pneumonia can cause pleurisy. Dehydration, lots of things can cause those linings to get irritated and inflamed. And it's really, really sharp and increased when they breathe deeply. So, Frank, you mentioned esophageal varices, and then there was a question mark because I had said at one point esophageal varices. I mentioned it. Um, so I'm not sure because I was tuned out from the chat, unfortunately. Um, but esophageal varices are terrible. These are varicose veins inside the esophagus um, that come from pressure from the liver. So when the liver is diseased, let me back up. Um, all of the blood from the GI tract, right? Everything from the GI tract drains and passes through the liver and then gets distributed to the body. So the GI tract, we're constantly taking in stuff, right? Some of that stuff the body knows it needs to filter out. And so the way it does that is it absorbs into the blood from the GI tract, passes through the liver, and then gets distributed. The liver detoxifies everything. Well, if the liver's diseased, right, just imagine like a cirrhosis or hard liver, right? It's hard. That blood that's draining from the GI tract hits pressure and it backs up. And so esophageal varices are like bulging varicose veins because they're hitting pressure in the liver inside the esophagus. And that's a really bad place to have a varicose vein because you imagine eating a little Dorito chip, right? And all it takes is one little cut of that varicose vein and it's just going to bleed profusely. If you've seen varicose veins on legs, you know that they've lost their integrity. They're just puffy, and if they don't have the ability to constrict if injured or anything like that, they're just um, pressurized and have lost their ability to change diameter, right? Because they're so puffy. Um, so as Frank said, the vomiting can rupture those. Sometimes they just spontaneously rupture. And when they do rupture, they carry a 50% mortality. The reason they didn't show up in this lecture is they themselves, as they sit there, are actually they're not painful, right? Your patients can have esophageal varices. They may know it. They may tell you it, but they don't have any pain with them just being there. I suppose if there was a tear in the esophagus and they tore as well, that would be painful. But yeah, those patients are very, very scary because they bleed like crazy and you can't stop that bleeding. And any liver patient, right? Any patient with liver disease already has trouble clotting because one of the functions of the liver, of which there are like literally 300 functions of the liver, is one of the functions of the liver is to form clotting factors, right? Your whole clotting cascade, all those fancy steps comes from things from the liver. So people who have a diseased liver have trouble clotting to start. So when they start bleeding, it's kind of like, that's why it carries such a high mortality. Thanks for bringing up the varices. I made a little quiz for y'all that I think will help us review some stuff. Sean, is it okay if I go through the quiz? Because I think it might generate questions as well. I'm not sure.
Yeah, for sure. Just be aware, guys, I was excuse me, made aware that the title on the top of the quiz is incorrect. So just cross that out and put thinking chest pain. I know it says sports related head trauma. That definitely is not Ginger's topic, even though I'm sure she'd rock that as well. But the questions are correct. So feel free to go through with that with them. Sorry about that mistake.
Cool. All right, let me find my quizzy poo. So I think one time I did multiple choice. This time I did matching. Here we go. All right, so what we're going to try to do, I'll make it bigger, is using the bank of words up top, 1 through 6. We're going to try to match that to, basically, I've written out the pathophys and some unique things about how they present. So there may be things in here I forgot to mention, but this can just be continued kind of learning activity. So let's look at the first one. A lesion in the stomach or duodenum causing gnawing pain. The pain is usually localized to the epigastric region of the abdomen, but can sometimes be understood as pain in the chest. All right, I don't think I really actually talked about this one. So the answer to that, let's see if anybody got it, is peptic ulcer. Good. Y'all got it without me even having to teach about it. So peptic ulcer is, there's confusion with the naming of all this, but a gastric ulcer, right? Ulcer in the stomach is a type of peptic ulcer. So peptic ulcer just means an ulceration somewhere in the GI tract. You can have duodenal ulcers, peptic ulcers. You've probably had, ulcer, you have ulcerative colitis in the colon. All of these are peptic ulcers. What ulcer means is an ulceration. It's a kind of hollowing out of the wall. And so in the case of a gastric ulcer, for example, you can eat away kind of at the lining of the stomach so deep that it begins to bleed and cause pain. And so there is a pattern where someone will eat and then that gets the stomach kind of chewing again, right? The stomach's kind of like a second mouth. It chews again, 3 layers of muscles that contract, and it causes this gnawing pain. It's epigastric. So epigastric, what that epigastric means is above the stomach. And so basically right under your xiphoid process, right at the chest, below that is all epigastric. It's over the stomach area. All right, the next one is there's a blockage of blood flow from the heart to the lungs. This results in a ventilation perfusion mismatch and impaired gas exchange. The pain is often sharp and accompanied by tachycardia and tachypnea. Cool, y'all killed that one. PE it is. Bam. The next one, a thrombus, which is a clot, lodges itself in one of the coronary arteries and blocks blood flow to a portion of the left or right ventricle. As the tissue dies, right, the heart tissue dies, it becomes weaker and fails to pump blood forward. The pain associated with this is often deep and dull. That one is acute coronary syndrome. Acute coronary syndrome is an umbrella term for angina, for MIs, for ST elevation MIs, for non-ST elevation MIs. Basically means acute, like sudden, coronary, like coronary artery syndrome. All right. Our next one says, after ingesting a large bolus of food, the esophagus can contract strongly and repeatedly, which causes pain. The pain is very intense and in a similar location as cardiac chest pain, which is retrosternal, meaning behind the sternum. Y'all all picked one. Esophageal spasms. Bam. Good job. The next one says infection in one or both lungs causes inflammation to the alveoli, and for exudate, Exudate is like pus that's coming out of cells to fill the smaller airways. Pain is provoked during coughing. Pneumonia. And the last one for this little chunk, I've got another chunk coming up after this one. A tear in the vessel lining results in a separation of the vessel layers, creating a false lumen, a false hole, and can decrease cardiac output. The pain associated with this is often tearing in nature and can radiate to the back. Everybody put aortic dissection. And in this case, it would be if it's radiating to the back, it's a thoracic aortic dissection. Bueno, bueno. All right. Next one. Inflammation infection of the sac around the heart causes the heart to rub on the sac, which results in sharp pain. The pain can be positional. It's often exacerbated by lying down and relieved by leaning forward. This one is pericarditis. So inflammation, infection of the sac around the heart. And there is a finding on the 12 lead EKG that is specific to pericarditis as well. Right. So this is another thing that an EKG can help you differentiate. Just like an MI, you can rule in pericarditis with some unique EKG findings. So maybe you guys only got page 1, but I can read it to you and we can all play along. All right, so the next one says, and hopefully you can see the screen. The next one says, during intense prolonged episodes of vomiting, the esophagus can tear. This is a rare condition and carries a high mortality. It's high mortality because it can lead to sepsis, right? And tremendous amount of damage in the chest from all these gastric contents going into the chest. The pain is excruciating retrosternal pain that can even refer to the left shoulder, right? So very confusing with MI, except for the story. They'll tell you a history of vomiting. Good, you guys got esophageal rupture. It has a fancy name too that I put in there in case you ever see it. You will have seen it before. I've only ever read it. I've never said it, so I don't actually know how it's said. Right. A rupture in the lung results in leaking of air into the pleural space. Because this usually occurs in one lung, the pain is unilateral and sharp. Good. This one is pneumothorax. All right, couple more. Inflammation of the pleural lining around the lungs results in sharp pain that worsens with deep breathing or coughing. The inflammation is often a result of viral infection by something like influenza, like the flu. This one's pleurisy. Good, you guys got it? Inflammation of the cartilage that connects a rib to the sternum, the breastbone, that causes pain near the sternum. Pain increases with deep breathing or when coughing. That's called costochondritis. Good, you guys got it too. And then our last one is about the pancreas. So inflammation of the pancreas can be caused by heavy alcohol intake or blockage of the common bile duct by gallstones. The pancreas can bleed or spill its contents, digestive enzymes, into the abdomen, leading to peritonitis and sepsis. You know, I forgot to mention that it can bleed. It's a really, it's kind of considered a solid organ in that it's very, very vascular. So when it's acute pancreatitis, you can get bleeding. So bleeding into the abdomen. 7 it is. Good, good. Boop. Awesome. What questions do you guys have about chest pain with our last minutes?
Sorry, we had to go on a call.
How was it?
Huh?
How was it?
Oh, it was great. So somebody, I don't know, sounded like anxiety to me.
Mm.
So arms were all tingly and so.
I didn't talk. Someone in the chat earlier said anxiety can cause chest pain, and I didn't really speak to that. It's totally true. It's another one of those diagnoses of exclusions, right? So we make sure it's not all that stuff. And then at the very end, we can say, all right, maybe this is just anxiety. Anxiety and hyperventilation syndrome, right? When people start hyperventilating, that can cause some chest tightness or chest kind of labored breathing. And the issue with anxiety is anxiety can accompany really serious conditions. And so because, things like MI, aortic aneurysms, when the body's really, really sick, you get this release of epi and all this stuff. You guys have heard that anxiety is an early shock sign, right? Unfortunately, anxiety can be one of the signs and symptoms of these really bad conditions. PE actually is a really common one. They have a sense that something's not right. They breathe fast, their heart beats fast, they're a little anxious, they're a little ramped up. And so it's our job to figure out, are they anxious because they have some life-threatening condition, or do they have, known baseline anxiety? And that's what's going on today. And the issue is people with known baseline anxiety can also have all these conditions. So it gets really, anxiety is like the last thing we'll all agree that it was that, right? And quite frankly, anxiety and depression is so prominent, right, in the US. So many patients have, are on psychotropic meds and things like that for anxiety and depression. And it's just their baseline. And they can totally be having all these scary things also. I know that females usually present differently than males with an MI. That's true. So we've built a lot of illness scripts around let's see, what's the right way to say this? Kind of the classic model of what we think, how these illnesses present. But the reality is, like, the typical MI is not typical. So more MIs present atypically than typically. So it's kind of funny. That perfect, radiating to the left arm and all these things is actually not that common. You're absolutely right. Women will often have, abdominal pain or no pain, and have other things like fatigue or something less specific to an MI, something more generalized. Same for people with diabetes, right? They don't have the same sensation. What type of right-sided STEMI is dangerous to give nitro due to the need for preload pressure? Nitro pressure drops equals death in the worst case. So all right ventricular infarcts, it's dangerous to give nitro to. So nitro is one of the strongest drugs we have in terms of changing body's physiology. It will, I mean, think of what it does. And we're giving it in pretty high doses. So to repeat nitro every 3 to 5 minutes, that's a lot. They're getting a lot of nitro. So it's really, really good at doing what it does, which is dropping preload, right? It drops blood pressure by way of dilating and dropping preload. The problem with right-sided MIs is a drop in preload. And so when you think there's a right ventricular infarct and you think that from EKG findings or from signs of right-sided heart failure, like JVD, we don't give nitro. I should say that some services will still keep it in their protocols to give small amount of nitro, like maybe nitro paste, and just have IVs ready to give fluids. So it may not be an absolute contraindication where you work. But to me, this is an interesting kind of thing when BLS providers are giving nitro without 12 leads. That being said, most right-sided MIs, right, the right ventricle, when it's involved, most of those patients are pretty hypotensive. And so you guys will not give nitro because they don't meet that criteria, right? They're too hypotensive to start. Any toxins or poisons that can cause chest pain, that's a great one. Toxic, a caustic ingestion, that's an easy, straightforward one in terms of this, esophagus burns. But you're asking about carbon monoxide poisoning. I don't know. Can you guys think of anything? I don't think of carbon monoxide poisoning. I don't think of chest pain as being on the list. I think of nausea and like flu-like symptoms and headache and confusion, but not chest pain. That's a good question. Oh, maybe chlorine, right? There's a lot of things we could inhale that burn.
Do you think maybe ginger on the lines of like secondary, the carbon monoxide poisoning causing enough stress and maybe a patient who's cardiovascular compromised to maybe develop chest pain more as like an MI? So now like you're talking about the worst case scenario where you're now trying to fight or combat both your CO and now an MI patient.
Yeah. And I fell into the classic pitfall of I forget it can be more than one thing.
Right.
I swear, like once a month, I get reminded of that. I'm like, oh, right, it can be more than one thing. The most commonly missed fracture on an x-ray is the second fracture.
Yeah, for
Right?
sure.
So a kid will go in with a broken arm and they find one of the fractures, right? And they attribute the pain that kid has to the fracture they see, but they didn't maybe notice there was a second fracture because they point to that, and it's called search satisficing. It's like call the search is over, we found the problem, and we quit hunting, quit assessing, unfortunately. 74-year-old male complaining of tearing pain and dizziness when standing. While taking blood pressure on the right arm, the abdomen was noticed to be pulsating. Oh, that's terrible. Gently palpated throbbing mass and decided to take less BP also. 14-point systolic difference, dissecting high or low. Well, that's a great point. The aorta can dissect up high, which it sounds like maybe if their blood pressures were unequal, it did. And it can travel the full length of the aorta, believe it or not. So there are CTs of people's aorta and then the false lumen right next to it of a full length aorta dissection and aneurysm along the full length of that thing. So it could have been both. Ha! Here we are again, thoracic and abdominal. He ended up with abdominal. Yeah, and so maybe those unequal findings on the right versus left, that also could have just been baseline. Or his vitals changed and trended, if you didn't get them together at the same time, close together. That's a good one. That one makes me think. He lived. That's so good.
Oh, it's nice when you have patients that live. Makes us feel like we're on the right track.
That's a good assessment that you guys noted all of that. It's very good. And look, he's 74, right? That's one in our illness script. That's one of our risk factors is age for these aortic aneurysms, dissections. You don't see it in young people very much unless it's trauma caused.
Just want to make sure there's no other questions trickling in before I talk about the end of this thing.
I will mention if so Medic Mindset, the podcast, 100% free. I truly make it because I love talking shop and love talking about all this stuff. If you in the next week would go listen to that episode, the Thinking Chest Pain episode, that spaced repetition of we just talked about it all, and then you're going to get to hear Brandon Blease talk about it again in his own words, slightly different words. That will make a lot of this stuff stick. It's on Apple Podcasts, Spotify. You can find it anywhere. He did a really good job he taught me a lot in that episode. A lot of that stuff I talked about tonight, I learned from him. And then I think I have maybe up to 7 or 8 of these with different chief complaints that you can check out.
Yeah, I got to say that the thinking shortness of breath one is all something. I think they're all really, really good, of course, but the thinking shortness of breath one is something we push to people on a pretty regular basis, as well as the listening in color is my new favorite one to just require that all of our EMS classes take a listen to that one. So if you haven't heard that one before, I think I might even put a little plug for that in my patient assessment one earlier in the season for them to go take a look at or take a listen to that one. That one's really good.
Yeah,
what's your most recent one?
Is
Thinking Lift Assist, I think, right?
Yeah, just put out one called Thinking Lift Assist, and it was a good one for me to listen to, and the guest did a great job of. She made this really interesting argument that we actually have to do our most advanced thinking on these lift assist calls. But who do we send? We send like a crew that's been told like you're just going there to pick someone up off. We tell them it's a lift assist, like they're just going to pick someone up. But the reality is like an adult not being able to get off the floor is very, very a sign of really, really bad health, and they need a pretty advanced assessment. So it kind of reframed lift assist for me.
I like it.
Mm-hmm.
Awesome. I'm going to steal your screen so I can just talk about
Nice.
a couple things.
Hi, guys.
And we'll let you questions come in, or if you want to chat a little bit longer, they can. But just kind of remind everyone when it comes to the submitting your post-test as well as your attendance sheet, you're taking a look at my screen now. Over here on the current EMS Live at Night courses, please make sure that you download the attendance sheet and the post-test here. On that attendance sheet is the link to send that to email. And then tomorrow, a link will show up to download the certificate. That's a writable PDF for you guys to print off and make sure you got some credit for tonight's lecture, as well as, like usual, you can find them on that YouTube channel. If you're not familiar with it, if you go to My Virtual EMS Instructor on YouTube, most of them are up there. I know Bryce's, when he talked a couple weeks ago, had some technical difficulties that didn't allow it to record properly, but most of this season, I think, are all up there. So feel free to check those out. And then just to give everyone, hang on one second here, everyone an update on what is coming up. This is the most updated version of our schedule. I was waiting to get some confirmation. The biggest one is Dan Limmer will be joining us. And I know Ginger's very familiar with him. I think he joined you on a podcast. That guy's super smart. He's on the February 25th. He has a presentation called When the Grim Reaper Wins, an EMS provider's guide to death with dignity. And so it was a topic he picked. I guess it's something he really enjoys speaking about. And then our 2-part EMS Live at Night in March, Holly Lytle, if you're local here in Spokane, is joining us from the Isaac Foundation and presenting it's a 3-hour presentation. So we're splitting it across 2. Hers is the autism in the wild. If you've never heard that presentation before. It's all about interactions with autism spectrum disorder kids and patients. She's the president of the Isaac Foundation. She works with local first responders, fire, EMS, parents, patients, everybody here in the Spokane region on dealing with autism spectrum disorder kids. So check that one out. And then April 13th, you can see motor vehicle crash with Matt Dill. And then April 22nd is the Sick or Not Sick Pediatric with Mike Helmbach. And then if I don't get any speakers signed up for May and June, I will be putting some topics out, and I will probably be the ones in front of the camera for those. So check those out. If you have any questions, feel free to stay on. But if not, you guys all stay safe, and we'll see you guys on the 25th. And Ginger, if you want to stay on just for a few minutes to see if anybody's got any lingering questions. If not, here in a few minutes, you are more than welcome to do whatever you guys do in Texas at 10 or 11 o'clock at night. So Jana, yeah, YouTube channel is My Virtual EMS Instructor. Gonna put it in the chat box for you. You just search that. Like I said, most of those recorded lectures are there. There's some recorded lectures from last season. I have some recorded lectures up from EMT classes I've done, EMT refresher classes I've done, just kind of all over the place. So feel free to, those sadly, because of the rules with NREMT and distributive education, those cannot be applied to the national component or the state and local component, but it can be used for individual hours. So feel free to check those out and use those for hours if you need to plug those into some CE credit spots.
Danny, how did this picture come through? You can be honest, because I have to do it again. You know, here we are on Zoom. Oh, you're muted.
I think it came out great. You know, like all things considered, I would just use like maybe a bigger pen or play with the lighting a little bit. It's totally different than the other one, and I like it. Yeah.
Yeah, like a fatter font.
And also, I'm just
Fatter
gonna
pen.
say it, like, because people have to acknowledge certain things that happen, but that was an awkward start, and people need to learn how to use mute, and people need to not say disrespectful shit. And I really respect you, just for plowing through.
Yeah.
Come on, you know. So, anyways, I had to say it.
Yeah. Thanks for acknowledging that. I appreciate that.
Yeah, for sure. All right. Well, I'll see you next time.
All right, man.
Thanks,
Take care.
Danny. We appreciate you.
Yeah.